Block 1 lecture covering end-of-life care. This lecture is mostly going to cover advanced directives, DNR status, hospice and palliative care, some ventilator withdrawal. There's a little bit of geriatric perioperative management in this lecture, but most of it will be more kind of form-based and knowing the basics of all of this kind of stuff. So jumping right in, first talking about advanced directives. What are advanced directives? So advanced directives is just a term encompassing quite a few number of legal documents. All of these provide instructions about your healthcare wishes in case you are ever unable to speak for yourself due to a medical condition. And so everything I'm going to talk about in this lecture is very specific to Ohio and comes from the State of Ohio website covering all of this information. So other states may have some differences, but since we're practicing in Ohio, I figured we would go over ours specifically. And so in Ohio, DNRs, living wills, organ donation, durable power of attorney are all considered advanced directives and are authorized by state law. And there are specific state requirements and forms that you can fill out for each of these, and we'll go through those here. So who should have advanced directives? Really, they recommend anyone over the age of 18 who can make his or her own decisions can complete an advanced directive form. And probably should. Some places recommend that kind of everyone have an advanced directive form completed. You do not need a lawyer to complete advanced directive forms. The state of Ohio has kind of blank forms that you can fill out. You can print off their website. There are some special exceptions that we'll kind of get into, or I guess how to complete these forms, that they have to be either signed, witnessed by a notary or two witnesses, and that there are some specifics regarding who the witnesses can be that can sign these forms, but we'll get into that later. So starting out on just advanced directives basics, what's the difference between your living will and your healthcare power of attorney? Because I think these two things usually run together. DNR status is kind of one of on its own, but living will and healthcare power of attorney can be a little bit confusing. So a living will specifically applies when a patient is terminally ill and unable to communicate, and the specific part of that is terminally ill. Versus a healthcare power of attorney becomes effective even if the patient's only temporarily unable to communicate their choices. So a healthcare power of attorney comes into effect and you have the very sick patient that comes into the ED, maybe they're septic and they need emergency surgery, but we've already intubated them. That's when their healthcare power of attorney comes into play to make those decisions of saying yes, they think we should operate or not. Versus a living will only comes into play when a patient is declared terminally ill by a physician. It's not considered a temporary measure. If a patient has both a living will and a healthcare power of attorney, and they are considered terminally ill, the living will is followed first. So in a terminally ill patient who has a living will, we will follow the directives that come from the living will, even if the healthcare power of attorney sitting in the room is contradicting and stating otherwise. We're supposed to follow what's in that living will because those were the choices that were made by the patient when they were filling out these forms. So that is assumed to be what the patient would want. And obviously we all know that sometimes healthcare power of attorneys may contradict what the actual patient would select themselves. There are basic Ohio forms, like I said, for all of these, but specifically living wills. In our Ohio form is pretty much set up so that if you do not want your dying process artificially prolonged, it's kind of all the check boxes you need to sign and check off and do all that kind of stuff for it. If you would like a living will stating that if I ever become terminally ill, I still want every treatment measure pursued, then you would actually have to have your own forms created by a lawyer. We don't have State of Ohio forms stating that kind of information. Ours are specifically for not prolonging the dying process. So starting with healthcare power of attorney, our Ohio healthcare power of attorney forms actually allow you to nominate 3 different people under this form. So the first one is your healthcare power of attorney. This would be the person who makes medical decisions for you if you are ever unable to or unconscious and unable to communicate your decisions. And that's specifically regarding medical decisions. So in the hospital, are we doing this treatment? Are we doing this procedure? There's a separate portion of the form where you can select a guardian to your person. And this comes into play if you ever to become incompetent. Most often this comes into play in cases of dementia and Alzheimer's, where patients aren't really able to make their own decisions about anything anymore, and this patient or this person undertakes responsibility to advocate for you as a person. So your needs of daily living, housing, clothing, food, all of that kind of stuff, they are responsible for kind of the day-to-day, everyday life stuff, is your guardian to your person. The third person is the guardian to your estate, and that would be someone to kind of take care of the financials and dealing with any property or housing or businesses or whatever that you would have. And these all can actually be 3 different people. So you can have someone making your medical decisions. You can have someone that you would select to take care of you if you were ever had severe advanced dementia. And then you can also nominate a third person if you think those first 2 people wouldn't do a great job of managing your money, a third person to kind of do that. So there are limitations when it comes to your healthcare power of attorney. They may only request life-sustaining treatment be withdrawn if you have a terminal condition or in a permanently unconscious state. You don't have to worry that if you ever became ill and needed short-term intubation, that your healthcare power of attorney could ask the physicians to remove the breathing tube. The patient has to be declared terminally ill. Your healthcare power of attorney can't do anything like that. They do not have the authority to withdraw the order or order withdrawal of comfort care. So if the patient was ever terminally ill and placed under comfort care, they can't ask the physicians to stop pain medications or that kind of stuff. That would continue on. If the patient is pregnant, life-sustaining treatment cannot be withdrawn. If doing so would terminate the pregnancy unless there is a substantial risk to the patient's life, or if 2 physicians determine the fetus would not be born alive. The healthcare power of attorney may not order nutrition and fluids be withdrawn unless the patient is terminal or permanently unconscious and 2 physicians agree that it would no longer provide comfort or alleviate pain. And then your healthcare power of attorney cannot withdraw consent that you have previously given unless your condition has changed or treatment would no longer be beneficial. So if you have already consented to treatment, they can't take that away unless things have drastically changed. So these are the actual Ohio healthcare power of attorney forms. That's the front page of it. Here on this page, this is the second page of it. So up top is naming your agent, or aka your healthcare power of attorney. That's giving their name, their relationship to you, the address, telephone number, and then you also authorize them to access any of your protected healthcare information. You can name alternate agents, and it's recommended so that just in case these forms aren't needed for a while down the road, and for whatever reason the first person you selected as your healthcare power of attorney is no longer able to, or maybe they're deceased at this time, you have alternate agents available to be able to make these decisions. And this is the guardian of the person that I talked about. Oh, geez. Sorry. Then we're back. That they would make your day-to-day decisions if you were ever unable to, such as food, clothing, living arrangements, but any sort of medical decisions would continue to be made by your healthcare power of attorney. That is where you would fill out this information. And then there's actually another page that covers the guardian of the estate that looks just like this and is the same format. And then this is kind of your signature page. And this is what I had mentioned earlier. For all of these state of Ohio forms, you require witnesses. So either you can have a witness or a notary on this form. The notary is probably easier because you cannot have anyone you have named on this form essentially sign this paper. So a lot of times these are your close family, friends, relatives, whatever. So anyone named on this form cannot sign it. Anyone related to you by blood, marriage, or adoption. So actually none of your family members can sign this form. And your physician cannot sign this form. So most of the time, I believe people have close friends if you're not going to use a notary to sign this form, because as long as they're not named on this form, they kind of fit the bill of being able to sign it. So going back to living wills, like we said earlier, this only comes into effect if the patient is terminally ill or unconscious and unable to communicate choices. So living will gives the physician the authority to withhold all life-sustaining treatment and permit you to die naturally. And that's how Ohio's is set up, so that... Hi, Reese. Sorry. We won't continue to pursue life-sustaining treatment in cases of terminal illness or a permanent unconscious state. There are a few challenges to this. Close family relatives are able to challenge a physician's decision regarding terminally ill or permanently unconscious state if they do not agree with it. However, family members are not allowed to challenge legally documented DNR status. So if you sign a DNR paper or DNR-CC, family cannot overturn that because you have signed that. That's not something that, if you have signed it when you are competent and able to make your own medical decisions, however, you become in a permanently unconscious state, family is not allowed to withdraw that. And like I said earlier, a living will takes precedence over a healthcare power of attorney. So physicians are supposed to follow what is written in the living will versus if there are disagreements with the healthcare power of attorney. So these are, again, forms, are Ohio living will forms. And this is the second page. The first page looks very similar to the healthcare power of attorney form, but this second page has contact information so that if physicians were ever going to implement a living will, they should attempt to contact these people on this page. This is always nice to know because sometimes patients present from a nursing home or an ECF or somewhere, and they just come with this packet of forms, and you don't have any sort of, there's no family at bedside, you don't know if anyone's been notified. If they have these forms, there should be at least contact people listed on there for you to get a hold of. And so, like I said, these are set up so that administer no life-sustaining treatment, including CPR. And then there's this special instructions portion of it to withhold or withdraw artificially or technology supplied nutrition or hydration if in a permanently unconscious state. So this is stating you don't want tube feeds forever if you're in a persistent vegetative state most of the time. And that you have to specifically sign down there stating. And also included in the living will is an optional anatomical gift portion, so patients can decide if they would like to donate their organs or body after their death as part of this form as well. So moving on to DNR status, just in case you weren't aware, a tattoo is actually not a binding DNR form, and if a patient comes in with DNR tattooed on their chest, you are still legally obligated to perform CPR unless they have a form. So DNR orders encompass chest compressions, intubation or artificial airway techniques, drug administration, cardioversion, defibrillation after cardiac arrest or respiratory arrest has occurred. That includes both. And as I mentioned in the other lecture, if you haven't watched that one yet, DNR does not mean do not treat in all cases. And we'll kind of go over our Ohio DNR statuses. So if, as I mentioned earlier, if the patient has a DNR form, family cannot demand CPR be provided. There are certain medical situations that may make decisions regarding care based on new medical information, and this does include decisions related to CPR, but I think that's a very rare statute for the most part. Once you've signed a DNR form, that's your family and anyone else making your medical decisions really shouldn't be allowed to demand changing that. So in Ohio, we have 3 types of code status, 2 types of DNR orders. So there's full code, DNR CCA, and DNR CC. And so DNR CCA, a patient receives standard medical care up until the point of arrest occurs. So that would be saying I can select DNR CCA myself and have this form signed. I would still receive all of my normal medical care throughout my entire life, but if for whatever reason, if I arrested tomorrow, they would not perform CPR. They would not intubate me if I arrested. However, you should intubate these patients if they come in for some other sort of medical illness that requires intubation. So you can prevent respiratory arrest, but if a patient comes in as DNR CCA already in arrest, then you should not intubate that patient. But if they're coming in for something else and just require intubation as a medical treatment, then you should still do that. Versus DNR CC patients, they receive care that eases their pain and suffering, but no measures to save or sustain life. So if a patient comes in that is DNR CC for a medical illness but have not arrested yet, you should not intubate that patient if they require it versus the DNR CCA status. So I think those are kind of the 2 kind of sticking points between those 2. CCA is normal medical care up until the point of arrest. CC is comfort care only and not pursuing significant medical treatment. So arrests in Ohio is defined as 2 different arrests. You can have cardiac arrest, the absence of a palpable pulse, or respiratory arrest, which they define as absence of spontaneous respirations or presence of agonal breathing. So in patients who arrest with a DNR order in place, we will section the airway, administer oxygen, position for comfort, can splint or immobilize the patient, control bleeding, provide pain medication, provide emotional support, and contact other hospital providers. When a patient comes in and arrests with a DNR order in place, you will not administer chest compression. There's no intubation of these patients. We do not administer resuscitative drugs, so there's no pushing epinephrine or amiodarone, no defibrillation or cardioversion, providing respiratory assistance other than just nasal cannula, essentially, or face mask, but no significant respiratory assistance. They actually say don't even initiate a resuscitative IV and do not initiate cardiac monitoring. So this is the DNR comfort care form or CCA. So the top is the DNR CC, bottom is DNR CCA. You put the patient's name, their address, and can have them sign it. I think it's kind of interesting to me, but their signature is optional on this form, and most of it is the physician information. And so at the bottom, we have to print your name as the physician, your signature, date the form, and put the date of the address of the hospital on there as well. And this, again, is just going over what we talked about. This is actually listed on the DNR form as well for the state of Ohio, going through exactly, and you can kind of walk through this with patients of what will happen if they arrest versus what will not happen if they arrest. Because that is the same for once arrest occurs, DNR, CC, and CCA are the same. So sometimes, especially patients coming in from SNF or ECF, they may have that kind of DNR CC paperwork. They may also have other forms, and these are other recognized official Ohio DNR forms. So there's a wallet card that you can print out and fill out and say, hey, this is what I have. And then I've actually seen 1 or 2 patients that have these DNR Comfort Care bracelets on them, especially if they come from a hospice type setting for whatever reason. They may have these forms on their person. And these are valid, acceptable forms versus a tattoo, which is not. These are legally binding in the state of Ohio. Sorry. My guard dog. So next we're going to talk about hospice versus palliative care pretty quickly. Just go into just a few details about the difference between the two. So palliative care can begin at the time of diagnosis and while treatment is ongoing. So say a patient is diagnosed with cancer and undergoing treatment, they can also simultaneously begin palliative care treatment. Because palliative care is focused on relief of symptoms and stress from the illness for the patient and the family. Versus hospice care is for when patients are deemed terminally ill and life expectancy is less than 6 months. And hospice care is for when curative treatments are stopped. So patient with metastatic cancer who's currently pursuing treatment can be a part of palliative care, but up until they cease treatment, they won't qualify for hospice. It's once treatments are stopped. And that life expectancy is 6 months or less. There is no penalty that if the patient lives longer than 6 months, but it's just supposed to be the physician saying that patient is acutely terminally ill. So what does hospice offer? Just so that everyone's aware, there are hospice physicians, nurses, social workers, counselors, home health aides, chaplains, therapists, and volunteers. They supply medications, medical equipment, supplies, and there is also inpatient hospice care available as well. And hospice provides up to 24/7 care, not only in their inpatient hospital or inpatient hospice areas, but they will also provide 24/7 round-the-clock care for patients in their home as well. In hospice care is constantly reevaluated. So 1 week a patient may need 8 hours of care from home health aides, and then the following week as things progress, hospice will reevaluate and they may provide 24/7 care. It's all about helping the patient and the family kind of provide the best treatment possible. So who pays for hospice? Medicare, Medicaid, and actually most private insurance companies cover the cost of hospice care. So it's at no cost to the families. So mixing it up a little bit, this was kind of stuck in this lump of topics, but some geriatric perioperative considerations. This information that I have on here is from the 2016 ACS and NSQIP geriatric guidelines. And it's a pretty quick review. They have a few more details than what I have in here, but it's not super extensive if you're interested in reading it or learning more about this. This could probably be a lecture all on its own, but we'll kind of touch on some of the high points here briefly. So preoperative management in geriatric preoperative management in geriatric patients. Kind of along with the theme of the rest of this lecture, you want to discuss goals of care with the patient. So why are we doing this operation? What is the patient hoping to get out of this? Confirm that they either have a healthcare power of attorney form filled out, or you are aware of who will be making their medical decisions. If they're married, usually it's their spouse is kind of the first medical decision maker. And just confirm that that's available just in case they were incapacitated after surgery for whatever reason. That would be in place. These guidelines suggest considering a shortened fluid fast with geriatric patients, in which they would drink clear liquids actually up to 2 hours prior to surgery. I'm not sure how many of our anesthesiologists feel about this. I have a feeling that a lot of them would not follow this guideline as much. So I would recommend discussing with your anesthesiologist before you just go and tell your patient that they can drink clears up to 2 hours prior to surgery unless you want your surgery canceled on you. They recommend continuing normal DVT and antibiotic prophylaxis as you would for any other patient. That doesn't change for a geriatric patient. And make sure to consider a preoperative medication review of your geriatric patients. A lot of them are on a very, very long list of medications, and being aware specifically of what they're on, what they need to continue, and what should be stopped prior to surgery. So just some intraoperative management of geriatric patients. The main things are those first two. Consider regional anesthesia techniques for these patients. If you can avoid general anesthesia and endotracheal intubation, it's probably best in geriatric patients. I know, I think I've done one inguinal hernia repair with Dr. Chambers that was basically under nerve block while the patient was awake and talking to us the whole time. That was kind of interesting. But consider some other options in these patients if available, depending on the procedure, obviously. And then also develop a perioperative analgesic plan. Multimodal pain control with opioid sparing is what they recommend in these patients. They highlight postoperative nausea prevention in these patients, so trying to get ahead of it while the patient is under general anesthesia to prevent postoperative nausea. Be sure to pay special attention to positioning to prevent pressure ulcers and nerve compression in these patients. And be aware about postoperative pulmonary complications and hypothermia and aggressive fluid management. These patients can very easily become fluid overloaded in the OR. It's something we should pay special attention to. This was just a nice chart in the NSQIP guidelines covering just some of the differences in geriatric anesthesia compared to your normal patient population. They can have more labile blood pressure, susceptibility to hypotension, volume overload. They can have an exaggerated decline in cardiac function. They are highly susceptible to residual anesthetic effects and have increased work of breathing, and aspiration risk is increased in these patients. Obviously, they have an increased risk of post-op delirium and cognitive function. They can have hepatic or renal issues that cause decreased drug clearance and are susceptible to AKIs post-op. So all just things to be aware of in your older patient population to kind of be thinking about. And then in these patients, post-operative management, they have actually a really nice post-operative rounding checklist of things that you should be thinking about every day when you're seeing these patients, and making sure that we're kind of doing everything we can for these elderly patients, starting with delirium and cognitive impairment. So optimizing pain control, their physical environment, minimizing lines and tubes and restraints, encouraging normal daylight patterns of having them up during the day with the shades open versus at night with lights off. I can't tell you how many times we walk into rooms and patients are just laying there in bed with all their shades closed and they're sleeping all day. So making sure to reinforce that with nursing care. Removing catheters and lines as soon as you can. Minimizing any psychoactive medications. In the perioperative acute pain, minimizing opiate use as much as possible. with pulmonary complications. The big thing here, early mobilization, ambulation, encouraging use of their incentive spirometer, getting a patient out of bed every day, and a lot of times making sure that they're out of bed and sitting up in a chair for all their meals. It always makes you nervous walking to the room and the patient's kind of halfway laying back in bed trying to eat lunch and you see them coughing on their food. That's just a huge aspiration risk. Minimizing fall risk on these patients. And I think we do a pretty good job of this just with all of our patients, but always thinking about nutrition status in these patients, starting their diets as soon as possible. If we're unable to restart their diet, and we're aware of that, trying to take steps to either TUPEs or TPN. And then also things we may not think of, but making sure they have their dentures available. Some patients don't have them in the hospital or don't bring them with them for whatever reason, making sure we can get those from home. UTI prevention, kind of going along with the delirium and fall risk and everything else. A lot of these kind of all feed into one another, but discontinuing Foley catheter as soon as possible. And then also kind of these last two, functional decline and pressure ulcers, going along with their early mobilization, getting them up out of bed, getting them in the chair. Obviously, our older patients are at increased risk for sacral wounds. So moving on to this last portion, just talking about terminal ventilator withdrawal in patients. And for this, we're just going to go over our specific Mount Carmel directives on terminal ventilator withdrawal. So to find actually our Mount Carmel policy, you can go to our @MC website. All across the top there are those little tabs you can click on. On the far right, there's one that says Work Life. And it brings down kind of another drop-down menu. And under there's tab Policies and Procedures. When you click on that, it opens up a new page, and you can type into the search bar terminal ventilator withdrawal, and that'll pull up this policy for you. Underneath that Policies and Procedures tab, you can also find pretty much all of our Mount Carmel policies and procedures. So if you're ever doing bladder pressures or anything else, stuff that you don't necessarily do all the time, but maybe need in the middle of the night, that's a good place to see if you can find our specific Mount Carmel policies for those. So just some of our policy basics. You must use the terminal ventilator withdrawal power plan that's in PowerChart. It kind of goes through everything step by step with you and kind of click the boxes as you're reading through it. It's a very well put together power plan, I think very easy to use. You are not allowed to use any verbal orders when it comes to terminal ventilator withdrawal. It must all come from this power plan. There is no Pyxis override medication during withdrawal. All medications must be verified by the pharmacy. Any medication dosing outside the power plan must be approved by the VPMA of the hospital, so pretty much don't do it. If it's not in the policy or if it's not in the power plan, you probably don't need it. Be sure to have extensive documentation of your discussion with family members, with nursing staff. You just want it all in the chart of these decisions being made. And then terminal ventilator withdrawal can only be implemented in the ICU or other approved units. I believe they specifically mentioned the palliative care unit, but they also state this may not be implemented in the ED. So if you have a patient that's intubated on the ventilator in the ED waiting on a room and family would like to withdraw, that patient actually must be moved out of the ED. This cannot happen in the ED itself. I think a big part of that is the nursing care that goes along with terminal ventilator withdrawal, and the ED nursing staff just doesn't have the staff available to do that close monitoring and one-on-one care. So these patients must be moved out of the ED before implementing any sort of withdrawal. So prior to withdrawal, there are a few things. Obviously, discuss with family. You want to make sure you're discussing with them the clinical picture of the patient, establishing goals of care and expectations, and prognosis. Clarify DNR status. Make sure the family members know exactly what they're deciding with DNR CC and palliative withdrawal. And they state in our withdrawal policy, ask the family to verbalize what will happen after extubation. You want to make sure the family can verbalize they understand that removing this ventilator, we expect the patient to expire after that ET tube is withdrawn. And then again, document all these discussions and these specific points in the chart. So after kind of talking with family, you want to make sure you're discussing with your care providers. As residents, we should never be doing this on our own. There should always at least have an attending notified. You discuss this with an attending. There are critical care physicians around as well if you have any questions. Following that discussion, make sure you're discussing with your nursing staff this plan for ventilator withdrawal, about the orders that are going in, the orders that you're changing, the discussions with family. You want to make sure everyone involved in the care of this patient is on board. And also discuss timing of ventilator withdrawal. You want to make sure that all of our staff is ready and available because it does take, specifically for nursing, quite a bit of documentation on their part. And then once kind of all these discussions are had, you want to make sure all these orders are in the computer. So you want to make sure the patient has a DNR CC order in the chart. You've initiated the terminal vent withdrawal power plan. And then also you can begin to start going through the rest of their orders, discontinuing any sort of treatment, transitioning over to comfort care, and discontinuing these monitor orders that the patient no longer needs in an attempt to make the patient as comfortable as possible. So the withdrawal process itself, number one, starting to prepare for the withdrawal. So you want to try to wean their continuous pain infusions or any opiate medications that they're on to the lowest effective level. You must stop all CNS depressing infusions and paralytics. So if patients on propofol or Precedex or a Versed drip, whatever it may be, those infusions must be stopped prior to withdrawal. And if they're on paralytics, those must be stopped as well. Immediately prior to withdrawal, make sure you're allowing for private time with the family, to visit with the patient, offer presence of a chaplain, ensure patient comfort level is appropriate before you're pulling the tube so that you're not behind, and discontinue any unnecessary monitoring that's in place. When the withdrawal is to occur, you want to discontinue the ET tube and the vent when the family is ready. And then nursing staff will continue to monitor the patient for distress, agitation, and restlessness, and continue to administer medications as appropriate. After withdrawal and the patient does expire, you have to document with the death note in the chart. Be sure to provide family privacy and support. And they also mentioned making referral for bereavement support if necessary or if the family requests it. And if the patient actually resumes respirations, continue to monitor, provide comfort measures, and if they're in the ICU, this is when you may consider possible transfer to the palliative care unit if they do continue to have some spontaneous respiration following ventilator withdrawal. So that's the end of this very happy and exciting topic. If you have any questions about all of this, there are plenty of resources on the state of Ohio's website regarding advanced directives, DNR status, and as far as our terminal ventilator withdrawal, I believe Dr. Chambers was on that committee developing this policy, and I know is very knowledgeable on all of that if you have any questions.